Disciples India learning from.
தெரியுமா
இது வாங்கலையா?
இந்த Viraja madam, speaker has joined the session. We can start.
Good evening, all. Disciples India Learning Forum welcomes you to this session. Unit of Disciples India Educational Resources Private Limited. Experience the joy of learning. Request you to kindly mute your phone, possibly can sit in a place where you are not disturbed. Request you all to ask questions at the end of the session. Remember, a new learning is always difficult initially, but becomes a habit eventually. Today's agenda: welcome and introduction, journey so far of DILF, guest speakers introduction, and the session. DIL Forum. Disciples India Group, Bangalore, is happy to present a platform purely for the joy of learning. It is envisaged to be an exciting learning platform where like-minded individuals and organizations can come together, share experiences, and learn and grow as individuals, professionals, and organizations. The objectives of the forum are to provide a platform to share and exchange ideas and experiences, to create and develop personal and professional network of learners, to enhance effective communication and leadership skills, to foster learning and contribute for personal and organizational development, to update with life management skill and contribute as an effective member to the society. Disciples India Learning Forum Organizing Committee members 2023, Dr. A.M. Suresh, Forum Advisor, Dr. B. Rupashri Tantri, President, Mr. Shiv Prasad K.M., Vice President, Mrs. Madhumati L., Secretary, Mrs. Viraja R., Joint Secretary, Mr. Akhilesh N.N., Assistant Secretary, Mr. Dilip A.P., Executive Member. Disciples India Learning Forum sessions so far. So 2018, 24 sessions, 2019, 25 sessions, 2020, 24 sessions, 2021, 8 sessions, 2022, 24 sessions, and 2023, so far, total of 114 sessions. So total of 114 sessions in a span of 5 years. So these were a few of the recent learning sessions which were conducted. Just the previous session that was conducted on 24th June 2023. So the topic was on achieving happiness through spirituality, the speaker being Mrs. Sharada T. Now, the present session, Disciples India Learning Forum presents, initiated by IQAC, 115th online learning session in association with IZ Group of Institutions presents the session on the topic pain assessment in palliative care patients. So may I now request Rupashri ma'am for introduction of the guest?
Yeah, thank you, madam. Good evening, all. It's my privilege to introduce the speaker of this session, Dr. Kavita Manjunath. Dr. Kavita has over 17 years of experience in the management of infectious diseases, chronic diseases, palliative care, elderly care, besides home health care. She is an MBBS graduate from Al Amin Medical College, Bijapur, and she did her post-graduation, that is DNB, in family medicine from a Bangalore hospital. She is currently associated with Portia Medical, which is the largest home healthcare organization in India, where she is working as clinical head of primary, preventive, and elderly care. She is a member of Family Physician Association. Being a selfless service-oriented doctor, she has a passion of creating awareness about the palliative care among people of all age groups through her talks and demos. And we are fortunate enough to have been given this opportunity to listen to her. On a personal note, I would like to mention a few words about Dr. Kavita. I know her since 2020 as a doctor with selfless service. When my father was very seriously ill, and she came voluntarily to provide treatment to my father. And my father was almost bedridden for almost 6 months. And it is because of her treatment that my father was able to have a peaceful end. So she's always a special doctor to me. She is very busy, and in spite of her busy schedule, she has accepted our invitation to conduct this session. On behalf of Disciples India Learning Forum, I extend a hearty welcome to Dr. Kavita. I welcome you, madam, and I request you to kindly start the session.
Sure. Thank you so much, Dr. Rupa. So good evening, everybody, and my respect to every individual present here. It was nice knowing about, Disciples India group. So at first, I would want to thank this forum, Disciples India Learning Forum. Very nice name, and all of us are interested to learn something or the new, any time, either within our subject or out of our subject. So that's very nice to know. All of you have joined here to know matters about different varieties of subject. So, and thanks forum for giving me an opportunity to speak, share my knowledge today on pain assessment in palliative care patients, which I received it from my senior palliative care physicians, which I'll be sharing it with you all. So I thank Dr. Rupa and her brother Tantri to giving me an opportunity to talk here. And let me tell you, this talk may be more appropriate for the medical team, the nurses, dentists, general physicians, maybe professors, because there's lot of use of medical terminologies in the slides and the talk, and can be a little difficult for the common public, general public to follow. As I heard in the initial introduction, that learning anything new can be difficult, but eventually, it can initiating can be difficult. Eventually it can become a habit. So that's very nice to know. So maybe even if you're not able to understand what those terminologies, you can note it down, and at the end of the session you can ask me about it. So let's get on to the talk, and let me start sharing my screen. Rupa, I think I'll be able to share my screen.
Yes, doctor, you will be given permission to share.
Yeah, I think I can share. Okay.
Yes, madam. I have now enabled, so you can now share the screen.
Okay. Okay.
Yes, we can see your screen.
Yeah. Let me take it on to the slide mode. I think I'll put off my video for the bandwidth, network bandwidth. Okay. So, but on my right hand side, how do I get out of this boxes? Any idea? Here, the join is links.
Ma'am, what boxes are you
it,
able
no?
to see there?
Yeah,
you just minimize it. That's
yeah, got it. Yeah. Okay, so the topic here was pain assessment in palliative care. I selected this topic because all of us, and at the nursing schools or the medical schools, we are not taught more about pain assessment. And, we have not been focusing more on palliative care. We have been taught how to take care of a curable disease, infectious disease. So palliative care is for those who. So palliative care, it is an interdisciplinary medical care given which is aimed at optimizing quality of life and mitigate the suffering among people who has serious, complex, terminal illness. So palliative care, especially for those incurable diseases, not for curable diseases. So the first slide. I'm not able to change my slide.
Ma'am, if you are using laptop, kindly press those arrow buttons, either that or your mouse. Keep it on the screen and just press it. It should move next.
It's not actually.
Okay.
Oh, yeah. Now I think you can see my second slide. Okay, now coming to the definition of pain, according to the revised definition from International Association for Study of Pain, it is said that pain is an unpleasant sensory and emotional experience associated with or resembling that is associated with actual or potential tissue damage. This seems like a complete technical definition, but each word of it is very important. We all have experienced pain. We all have varying degrees of experiencing different intensities of pain. So pain, it means it is unpleasant. Pain is unpleasant. It is a personal experience. Each person will have different perception of pain with the same stimulus of pain. So the degree of biological, social, psychological factors influence the perception of pain. You see, there's some terminology. Pain and nociception are different phenomena. Pain is a subjective experience of an actual injury or an actual harm. Now, this terminology called nociception. Nociception is a physiological phenomena. It is a neural processes of encoding and processing a noxious stimulus. Okay, so that is how it helps in perception of pain. And this perception of pain depends on degree of various factors. Now, pain usually has a protective role, protective function. This is because, you see, when there is an injury, it stimulates all the sensory receptors at that particular area after a tissue damage. Not only it heightens the sensory sensitivity, but this pain also assists in the healing of the injured body part, by creating a situation that discourages physical movement or physical contact. So, for example, if you can think, if there is a small fracture at any one of your limb, what happens, that part of the limb, because of pain, we will not try to move it. We will try to keep it in one particular position where there is less pain. So by keeping that in that particular position without movement, it actually enables faster recovery and faster healing. So pain sometimes also has a protective role or an adaptive role. So this is what it says. But when it becomes chronic, that is when the pain becomes prolonged, it adversely affects our physical, social, psychological, and functional well-being of a patient. So, and how a person expresses the pain, or how we know that a person has pain, it can be either verbal or maybe non-verbal. So we will learn, in the coming slides, how a patient who cannot speak, who is unconscious, patient with dementia, or a neonate, an infant, a child, how do we get to know that they are in pain? We should also remember that, if a person is not able to communicate verbally, it does not rule out the possibility of experiencing pain. So the pain expressions can be both verbal and non-verbal. So pain is what the patient says it hurts. So we go by what patient says. Here we are not talking about, malingering patients. Malingering patients, meaning people who are who doesn't have pain, but they're just acting to have pain just to avoid certain circumstances. We are not talking about that pain here, or we are not talking about a child who is simply complaining of headache or stomach pain just to avoid going to school. So we are talking about the actual pain, and we go by what the patient says. So pain is what the patient says it hurts. Incidence, what's the incidence of pain? Pain is the most common symptoms of patients who are presenting in palliative care. 2/3 of patients with, advanced metastatic cancer has pain. Advanced metastatic cancer means the cancer which is in its last stages and it has spread to different organs. So 2/3 of these patients do experience pain. So 70% of advanced cancer patients do suffer from pain. It's not only cancer patients, patients with other non-cancer illness like heart disease. CAD means coronary artery disease. Heart disease, CRF is kidney failure, renal failure. COPD, or chronic obstructive pulmonary disease, lung disease, obstructive lung disease patients. So 40% of these patients too, non-cancer illness, disease related patients too experience pain. Pain is also experienced by HIV patients. 50% or more than 50% of them who are ambulatory, and almost 80% of them who are admitted HIV patients do experience pain. So this is the incidence of pain. Now coming to dimensions of pain, you see, on my left, on the left hand side of the slide, we have this doctor, Dame Cicely Saunders. She was a founder of modern palliative care. She became a physician in the year 1957, who actually started studying pain control in patients with advanced cancer. and she was pioneered in using regular use of opioid analgesics by the clock. So she was the founder of modern palliative medicine. So she, gave up the concept of something called total pain concept. So that means to say pain is not only physical, pain is also spiritual, pain is also psychological and psychosocial. So all of these are the causes of pain in a patient. So it's just not physical pain a patient will have. He will have other causes of pain, which could be spiritual, psychological, and psychosocial. There was a study done at AIMS. It was quite a big study, where they included a lot of patients who suffered from cancer. So in this study, they realized that physical pain only contributed to 1/3 of the pain they had. 1/3 of the pain in most of the cancer patients. So the remaining was not at all a physical pain. So physical pain was only 1/3 of the pain. So what can be the causes of pain in a patient? So the physical component of pain is because of the tissue injury, the underlying damage to the tissues which has happened either because of a road traffic accident or an inflammation or an infection. The treatment effects, fatigue, pain can be due to cramps, pain can be due to lack of sleep. The emotional component can be due to anger, because of fear of death, feeling of helplessness. So emotional component can also increase physical pain. To go to the social causes, family worries. If any of the family member is diagnosed to have an incurable disease, life-threatening illness, the whole family who is attached to him is worried about him. So the patient is worried about his family. So this is a type of social pain he is suffering from. Loss of income. For example, a head of a family, he suddenly becomes dependent because of his disease. And he's not able to go to work, he's not able to attend his office. So because of him, this the income to the family has reduced. So this loss of income becomes a type of social pain for him. Loss of social role. For example, chemotherapy patients, who patients who are receiving chemotherapy, the side effect of the chemotherapy can be loss of hair, loss of body image. Because of this, they don't want to come out. They're not able to go to work, they're not able to attend office, they don't want to socialize. So this becomes a part of social pain. They get isolated from the other members of the society. So all these forms the social causes of pain. Then comes spiritual. Spiritual is, patients can think, why me? Why I have got diagnosed with such a incurable disease? Why I have got cancer? Or they might think, have I done anything wrong? Is there any unresolved guilt? Some sort of depression? Have I harmed anybody? Why am I suffering? Or if a child is suffering from a cancer, the mother might think, what have I done for my child to suffer? So there are a lot of things spiritually they think, and this causing the spiritual part of pain. So total pain comprises all this, and it is just not physical pain. So all of these increase the psychological issues that increase the perception of pain. So this we should understand. Now this slide shows that pain experience and behavior is influenced by the development of the nervous system. It's also influenced by certain cultural factors, psychological factors, emotions, environment. All of these affect the pain generating mechanisms. Also, there is somatosensory inputs, the sensory inputs from the physical pain. And there is neuronal changes happening, changes in the nervous system, nerves, and genetic changes, which usually occurs in a chronic pain or a prolonged pain. So all these neuronal changes, genetic changes, leads changes in the nervous system. So all of these affect the pain experience and behavior of the patient. Now, coming to causes of pain. What are the common causes of physical pain? Here we're concentrating on physical pain in this slide. So it can be disease related, the underlying cancer, the underlying inflammation, underlying infection of any organs. The cancer spread to the nerves is compressed, or cancer spread to bone. Muscle spasms, muscles go into severe spasms. There's something called lymphedema also causing pain. Lymphedema is it's a swelling which comes up due to buildup of lymph fluid in the body. So there are something called lymph nodes in our body which acts like a drain in your sink. So if the drain is clogged, the fluid cannot drain in the sink. Similarly, if these lymph nodes in our body gets destroyed either by removal or damaged by cancer treatment, radiation, so they don't drain the fluid from the body. So they build up the lymph fluid in the body and then causes swelling and pain, cramp-like pain and swelling. So this usually happens in upper limbs and lower limbs. So this is lymphedema. Raised intracranial tension. That is, see, there is some amount of how we call blood pressure. Similarly, there's some amount of pressure in our brain, and that's called intracranial pressure. There are certain conditions or diseases which can affect the brain and can increase the pressure in the brain. So that's called raised intracranial tension. So raised intracranial tension, raised ICT, can also cause severe pain, severe headache. So these are the disease-related causes of pain. Coming to comorbidities or the chronic illnesses which most of us suffer, like arthritis, severe joint pains, joint swelling, arthralgia, angina, the cardiac pain, heart pain, myalgia, muscle aches, muscle pains. So these are other causes of pain. Sometimes pain can be treatment related itself. Surgery, we all know surgery can cause pain. Post-surgery, there can be some amount of pain for few days. Chemo medications can cause, as a side effect, they can cause severe mucositis. Mucositis means inflammation of the mucosa, the lining in our mouth, the wet lining in our mouth, the buccal mucosa, the tongue, the palate. So these can get affected, they can get inflamed, and we can have severe pain. So this is called mucositis. Chemotherapy medication can cause diarrhea. Radiation, some of our patients are receiving radiations for cancer. So radiations can cause burns. Certain medications can cause a lot of side effects. There is no medication without any side effects. So medications can also cause side effects, which can cause pain. Debility related. Debility means physical weakness, severe physical weakness. Because of physical weakness, patients become, especially the elderly people, old age people, they become bedbound. Because of their continuous long-term bedbound status, what happens, they will start developing secondary complications like bed sores. We call them wounds at the back, where the back skin, the gluteal skin, the buttock area, the skin at the buttock area, or the skin at the heel region, the skin at the upper back, which is in constant touch with the bed. There is no air exchange there. There constant touch. There is constant pressure. Because of this constant pressure, the skin can break open and lead to wounds. So this is called bed sores or pressure sores. So this itself can cause severe pain in them. Since they are continuously bedbound, they can have constipation. Constipation can lead to pain in the lower stomach, lower abdomen. then we have bladder spasm, urinary bladder. The muscles of the urinary bladder can go into severe spasm. So these are various causes of debility related pain. So this means to say one person can have more than one kinds of pains. So this we have to keep in our mind. The slide was mainly to tell you that it's not necessarily that the pain is only because of the disease. It can be due to his other medical conditions he's suffering from. It can be due to the medications he's taking, the treatment related, or his debility related. Now, but what happens, when we come across a patient with a pain, you can either take it as a non-medical person or a medical person. What we usually tell, is generally our view will be as a non-family member, oh, it is a part of your disease. You may have to bear it. This is how my thought process may go. Or sometimes if you're a doctor, you're a nurse, if you're trying to think what else can I do, we might think that what can we do to relieve the pain from this person. So there can be different types of thoughts. Either we might blame it on the disease, or we might also think, what can I do to relieve him from the pain? This is because why all these thoughts is because we have not been taught about pain management in particular, and there are many barriers for pain management. The barriers are: pain is not properly recognized, pain is not properly assessed, pain is not properly treated. Let me tell you that it has been studied that doctors, nurses have a low competence in pain assessment, about 76% of them. And opiophobia. What is opiophobia? Opiophobia is a fear of, we are afraid of using opioids because we think in terms of only addiction. Opioids are a very good analgesics for patients who are in their terminal stages, for palliative care patients. They are very good analgesics, but we only think in terms of addiction. So that fear of using opioids is also a barrier for a proper good pain relief. And a poor training in medical school. It is not taught properly in any of the nursing schools or the medical schools, how to properly recognize the pain, assess the pain, and treat the pain. So it's found that 88% of poor training happens in medical school of pain. Now, coming to how do we classify pain? Just basically, it might be of interest for the students if in this group. Pain can be classified based on duration. We call it acute pain, chronic pain. Acute means the pain which is the recent, which is within 1 or 2 months. Pain has arrived within 1 or 2 months or 3 months. Chronic pain is a pain which has been persisting for more than 3 months. So it's a prolonged pain. Pain can also get classified by the nature of the receptors. We have receptors which will catch up the stimulus. So it could be nociceptive pain or non-nociceptive. Now, what is nociceptive? See, there's a receptors called nociceptors. Nociceptors are sensory receptors, that detect the signals from a damaged tissue, and they also respond to the chemicals which is released from the damaged tissue. Okay, so these nociceptors are free nerve endings which are found in the skin. They are found in muscles. They are found in joints, bones, and also in our viscera, the organs, various organs. So these are called nociceptors. So all these receptors are found all over our skin, or joints, bones, muscles, and in our organs. So they detect the signals from the damaged tissue, and that is how we try to perceive that pain. We get to understand that there is a pain there. So it is through these nociceptors. So it could be a nociceptive pain. When the skin is involved, it's called somatic pain. When the organs are involved, it is called visceral pain. Non-nociceptive is when the nerves are involved, spinal cord, nerves. So that's called neuropathic pain. Okay. Now, something about acute and chronic pain. Acute pain is transient. It usually indicates that there's a tissue injury, an actual tissue injury, or there can be a potential tissue injury. Usually, the pain which we usually come across in our daily routine practice at hospital or clinics, in case of road traffic accidents, there's an injury to part of a body. There's a trauma. So that injury has caused pain, or a surgery done will post surgery, there will be pain for about 2 to 3 days, and patient will be given pain medications. So usually, and in case of renal colic, we call it, stones in the kidney stones can cause pain. Burns can cause pain. So all these are indicating that there is an underlying tissue damage or tissue inflammation happening. So that is acute pain. Acute pain is usually self-limiting. That means to say, as the tissue damage heals, as it recovers, as the patient recovers from surgery, as the patient recovers from the disease, as the patient passes off the stone from his kidney, his pain gets relieved. So acute pain intensity reduces as the healing continues. And usually acute pain has a protective role. It has an adaptive role. I have explained to you what is this adaptive role in the first slide. And acute pain is also associated with autonomic symptoms. See, autonomic symptoms means there will be swelling, there will be redness, there will be raised temperature of that area of injured part of the body. So in case of acute pain, they will have this associated, we will get to see this associated symptoms. The nurses or the doctors here will be able to understand it. So acute pain is associated with redness. Hello. Okay. Acute pain is associated with autonomic symptoms like redness of that part of the limb, inflammation, pain, and local rise of temperature. So acute pain is actually a symptom. Now, when you come to chronic pain is a pain which persists for more than 3 months. And it persists beyond the healing of injury. Frequently, there is no clear-cut cause to understand chronic pain, no clear-cut cause. So pain is usually disproportionate to our clinical findings. Usually, in acute pain, we will be able to tell, by examination, what could be the cause of this pain in case of acute pain. Chronic pain, it can be a little difficult. Usually here, it is not the nociceptors which is involved. Here it is the nerves which is involved, spinal cord. So it is neuropathic component is present in chronic pain. There are no signs of inflammation. Here it is neuropathic component, which is common, like in example, a cancer patient, HIV patient, diabetic neuropathy. So they can have multifactorial with neurochemical changes. So there is permanent neurochemical changes in the nervous system, both in structure, anatomy, and physiology of the nervous system, both in the peripheral nervous system and in the central nervous system. Now here they can have vegetative responses. What is vegetative responses? Like I told you, in acute pain, patient will have redness, swelling, and in acute pain, patient will be rolling in bed. He will have a curved position. If he has a stomach pain, he will curve up himself and try to keep his hand on his stomach, and he's in severe pain when he'll be screaming in pain in acute pain. But in chronic pain, patient is not screaming, not rolling in bed, no sweating, no vomiting, no nausea. They will only present with vegetative responses. That means lack of sleep, lack of appetite, lack of libido, lack of interest in life, social interaction will go down. They're just quietly lying down at one corner of the bed, facing the wall, and they're very silent. So it also has a psychological component. So these are the main features of chronic pain, and this is unremitting because the disease is progressive, like cancer, HIV, diabetic neuropathy, and its chronic pain is a constant reminder of a life limiting illness. Now, what happens in acute pain, it can have effect on other systems of our body. It on heart, it can cause increased heart rate. We call it as tachycardia, increased blood pressure. Because of severe pain, some people can get into blackout, syncope, get into a spell of unconscious mode for few seconds or few minutes. That's syncope. It can affect on lungs by causing increased breathing effect, increased respiratory rate, that we call it as tachypnea. There can be splinting effect. That means in case if there's an injury to the chest, person will not be, he will try to restrict the movement of his chest while breathing so that it doesn't cause pain. So that's called splinting effect. And he will not be able to cough. He'll have inability to cough. On the endocrine part, there can be raised sugars, reduced immunity in case of acute severe pain, and decreased movement. They will not be able to move that particular part of the limb which is injured. Chronic, in case of chronic pain, the effects are, as I told you, vegetative responses. They restrict their social activity, they restrict their physical activity. It affects on their work. There is decreased income in the family. There's disharmony in the relationships. It produces social isolation. It can cause depression. It increases anxiety. And the vegetative symptoms are more common, like lack of sleep. He or she may not sleep at all. He can have insomnia, loss of appetite, reduced food intake, loss of interest in life, social interaction will go down, and they're just quietly sitting on one side of the home. So these are the effects of chronic pain. Now, a type of pain, this has already been discussed. You see, nociceptive. I've told you the nociceptors, which is present over the receptors, which is present over our skin. When that gets stimulated and causing pain, that's called somatic pain. Visceral pain, when the organs are involved, the internal organs, heart, lungs, kidney, liver, brain, when all these are involved, when they are in pain, when those receptors are stimulated, when that is causing pain, that's called visceral nociceptive pain. And it can neuropathic pain when the nerves are involved, when the nerves are damaged. For example, in case of amputation, when the leg had to be amputated for a patient who has a diabetic gangrene, when his legs gets amputated, the nerves also gets damaged, so he can have a neuropathic pain, which is a prolonged pain and can persist for more than 3 months. So that's neuropathic pain. And it is found that in cancer patients, they can have mixed type of pain, both nociceptive and neuropathic type of pain. Now, why is this important to know different types of pain, like acute, chronic, nociceptive, neuropathic? Because, the underlying pathology is different, the presentation is different, the management is different, and the prognosis is different. So that's why we need to know the different types of pain. Only then we will be able to give a proper relief in a patient for control of pain. Now, to understand, management of pain, I think, for the students, medical students or nursing students who are in this group, they should know the neuroanatomy of the pain. Think of an injury at any site of our body, just an imagination, injury at your wrist. Think if there's an injury at your wrist. What happens? The receptors at that area, the wrist areas, they get stimulated, and that pain, you can see the nerve fibers, which is in this diagram, A beta, A delta, C fibers. And there are different types of peripheral stimulus because of different types of injuries. Now, this message is carried by these nerve fibers. These are called efferent pathways. So there are afferent pathways going upwards to the spinal cord, first to the dorsal root ganglion, and then this is the spinal cord on the right hand side. They go to the spinal cord, and then from there to the spinothalamic tract, and then to the higher centers in the brain. So in the brain, at the higher centers, where the perception of pain happens. Perception of pain happens, and then they come down through efferent pathways, and then it will affect our motion and movement of the injured part. Now, the fibers which are involved in the transmission and perception of pain are two types of fibers, the A delta fibers and C fibers. These are responsible, to transmit especially the pain sensation. Now, these fibers, it is seen that they have ramification. Before they go into the brain, the cerebral cortex, they have ramifications below the thalamus. They have networking with the limbic system of our brain. That is the reason why there is emotional component associated with pain. There is crying, there is depression, there is anxiety, when there is fear, when there is severe pain. So networking with the limbic system in the brain is responsible for the emotional component of the pain. And then networking with the reticular system. There's a system called reticular system. When these fibers network with the reticular system before going to the brain, this leads to sleep disturbances. That's why we don't feel like sleeping when we have pain. When there's a pain, we cannot sleep at all. So that's because these fibers, they get, when they're going to the brain, they also network with these different systems, limbic system and reticular systems. So afferent pathway is the pathway where the message is carried from the site of injury to the brain. That is from the nociceptors, that through the A delta fibers, C fibers, goes to spinal cord, spinothalamic tract, and then to the brain and other higher centers. Now, in the brain, the pain is processed and then perceived, so that your emotions, feelings, sleep, hormones, all of these get affected by the pain. Okay. Now, the modulation of pain occurs in the brain. They stimulate, this is the efferent pathway, that is the message coming from the brain to the injured part. The modulation of pain occurs in the brain. They stimulate the midbrain, they stimulate the descending pathways. Here, some hormones, chemicals are released called 5-HT and noradrenaline. These are released in the descending pathways, and they act on the spinal cord back again. And this is where they can inhibit the signals or block the signals or change the perception of pain. So I think you may not be able to understand it completely by just one talk here. You may, if interested, you can go back to books and go through this physiology of pain. So then it's very interesting, and you will get to understand how we perceive pain and how pain gets modulated and processed. But the most important thing what you should know is, unlike olfactory receptors, see, that means unlike the receptors in our nose, for example, when you enter a restaurant, or when you enter into a kitchen of your house, where there is a very spicy dish or a tasty dish which is being cooked, as soon as you enter, you get the smell of it. But how long can you keep getting the smell of it? Maybe for 5-10 minutes. After that, what happens? You stop smelling it, because the receptors in your nose get used to that stimulus and they no longer get excited. But pain receptors are different. They do not adapt over time. When there is an injury or a tumor in any part of the body, there is chemical changes at that part of the body. The receptors, they are getting excited, and they release certain chemicals. There is sensitization of receptors in that area, and they go to the spinal cord, and that related part of the spinal cord gets excited. But they are not limited to that particular area of damage. You see, the chemicals which were produced at the area of damage, what they do is they will excite the neighboring receptors, neighboring sleepy and silent receptors. They also get excited because of the chemicals received. And when they go to the spinal cord, they excite the adjoining areas of the spinal cord. The above segments and the below segments of the spinal cords also gets excited. So there is a lot more and more recruitment of receptors, the neighboring sleepy and silent receptors, both periphery, and there is recruitment of adjoining spinal cord above and below. And this is how there can be reduction in modulatory inputs from the brainstem. All of these work to increase the worsening in intensity of the pain, increase the severity of pain, and extent of pain. So this leads to a vicious cycle of pain. Okay. So how recruitment happens, this I have already explained to you. There is peripheral recruitment is due to the neighboring silent and sleeping receptors also gets excited because of the chemicals produced at the site of injury. Central recruitment is because the newer areas in the spinal cord, the above segments and the below segments can get excited. So there is secretion of chemicals, which leads to recruitment of sleepy and silent nociceptors, so that more of receptors and in the spinal cord, newer areas of spinal cord segments get excited. So, and they start responding to any one painful stimulus. Something peripheral sensitization, there's something called peripheral sensitization, central sensitization. Peripheral sensitization happens at the site of injury. The receptors at the site of injury get stimulated. Here, prostaglandin is a chemical which is produced. It makes the nerve endings more sensitive to other pain-producing substances. NSAIDs is a medication which we usually give it to patients to relieve pain. They usually block the production of prostaglandins and help prevent pain. Okay, and central sensitization, here the nervous system becomes more sensitive in perceiving pain to a given stimulus. That's called central sensitization. So all of these act together, so there is more and more pain, and this leads to continuous pain. So even a small signal or stimulus normally which does not cause pain can cause pain, and this is called hyperalgesia. For me it could be a stimulus which is not causing pain, but for others a stimulus which is not causing pain can cause severe pain. That's called hyperalgesia. Or even a non-nociceptive stimulus, like just touching of a cloth, which usually does not cause pain, can cause pain. This is called allodynia. For example, in an infection, viral infection called herpes zoster. Here in patients with herpes zoster, they even can't wear clothes. The touch of the cloth on their body that can cause pain. So that's called allodynia. Muscles can get into spasm, causing pain. There can be vasoconstriction, blood vessels going into constrictions, causing pain. Loss of blood supply to that particular area can cause pain. That's called ischemic pain. So there are, this means to say there are many mechanisms through which vicious cycle of pain can occur, pain can occur, and there is more and more of pain caused due to underlying medical conditions. Now, pain has many components. It can be sensory in terms of intensity, recurrence of pain. The emotional part can be we can be anxious, we can be depressed, there can be no sleep because of pain. Heart rate can increase, there's sweating, there's raised blood pressure. Motor, we won't be able to move that particular part of the limb, reduced functions of that particular part of the body. Types of pain, we have already read this: nociceptive and neuropathic pain. Neuropathic is the involvement of nerves, nociceptive is the involvement of the receptors. Now, in case of nociceptive pain, somatic pain is the superficial skin related pain. The pain is always localized. Here it's not a continuous pain. It can come and go. Pain can be throbbing, it can be cutting like, and this type of pain is usually worsens with movements. And this happens when the soft tissue, the muscles, and bones, periosteum is a covering of the bone. When these gets damaged, this leads to somatic type of nociceptive pain. Visceral pain, when the organs are involved, the underlying organs are involved. Here, what happens? The pain is poorly localized. Usually, the pain can be continuous, like kidney stone. The pain is very continuous, cramp-like pain. Appendicitis, continuous pain. In a patient doing there is no difference in the movements. However he moves his limbs, the pain is the same. Okay, so various other causes. Neuropathic pain, we have already gone through this. Now, some pain terminologies: analgesia means stopping pain. Hyperalgesia means it's an increased response to a normally painful stimulus, an increased response. Allodynia is pain by a stimulus that normally does not evoke pain. Like I gave you an example of an viral infection called herpes zoster. In those patients, just even wearing clothes is difficult. So touch of a cloth can also cause pain for them. That's called allodynia. Referred pain is, pain perceived at a location other than the site of the painful stimulus or the origin of the stimulus. This is because of the networking of interconnecting sensory nerves. So there's a network of interconnecting sensory nerves which can cause referred pain, like in cardiac pain, heart pain. When there's a chest pain, we usually ask, is the pain radiating to your left arm, your neck? So this is how we ask certain referred pains. Sometimes there can be some pains are more difficult to treat than others, mainly because of it's not properly assessed, or there are somatization. There could be emotional factors as physical pain, like stress can cause headache, stress can cause back pain, stress can cause fatigue. So that's called somatization. Opioid unresponsiveness. Some patients, are not don't respond even to opioid analgesics, and opioid neurotoxicity. So some pains are more difficult, to treat. Coming to social pain, this is important here. See, what is social pain? There may be effect of emotional and social distress on pain. And pain is associated with anxiety, fear, lack of sleep. And, remember I told you that, before the pain goes through afferent pathways to the brain, they have ramifications below the thalamus. They have networking with the system called limbic system, reticular system. So all of these act, and there is overlapping of all these brain circuits, and that's how it causes a severe pain. It is not like all of these act physiologically. It is not like people say this person is very emotional or very sensitive, he or she is just reacting to a simple pain. It is not like that. It is different. Brains are wired differently. So there can be physiological reasons for different responses to pain with different persons. So that we have to understand. We just cannot say, he's very sensitive, he just overreacts for a pain. It's not like that. Okay. So also it is very important for us, why is it important? Because we must tell our patients, early treatment of pain is more important to prevent long-term damage or permanent damage to the central nervous system, the nerves. Early treatment is very essential. If the pain is continuous, unremitting continuous analgesia around the clock may be difficult, around the clock may be required. Prevention is better than cure in pain also. At the same time, regular review with the doctor, regular follow-up, titration of the drugs, modification of the drugs also becomes an important part for a proper pain relief. Now, this is just for the students here, how pain assessment in our textbooks, we have PQRST, trying to understand provocative factors, what makes the pain better, what makes the pain worse. We are trying to come up to a diagnosis by asking these questions. Quality, we are trying to ask, what is the quality of pain? Do you have throbbing pain? Do you have nagging pain? By this, we try to, there are some certain conditions which can have a particular type of pain, particular quality of pain. Some pains radiate in a particular way. So cardiac pain, usually left-sided chest pain, which usually radiates to the left arm, left upper limb, or the neck. It doesn't come towards the right side. So when there's a right-sided chest pain, we usually rule out heart-related pain. So that's how we try to assess in our history. Severity of pain, we try to understand, how bad is your pain, how severe it is. Temporal factors, which part of the day the pain is very severe. It's in the daytime, at the dawn, dusk, or during your sleep. So all this helps us to come up towards the diagnosis. Also, we also ask about how bad is the pain. There are some tools, scales which are used. If you go to a doctor, usually a doctor will use these tools to understand how severe is your pain. There are simple ones provided for day-to-day practice. OPDs have a different scale. Some are used in research purpose. Some are used in institutions. So you can decide which is best for your kind of work. The maximum used is given here, like rupee scale. So rupee scale, in case of an uneducated lady, an elderly person, we ask them, out of 1 rupee, what do you feel? Is it a 50 paisa pain, 25 paisa pain, 75 paisa, or is it 1 rupee pain? This is how we try to rate ask the severity of pain. Descriptive scale, it is as per the faces here on the right hand side. You can see smiling face, a sad face, a silent face. By this, we try to understand what is the type of pain. If he's smiling, if he shows a smiling face, it means pain is present but does not limit the activity. So it's a sad pain. That means to say, because of pain, is unable to do most of the activities. A crying face, unable to do activities because of pain. So that's how we try to understand. There are numerical scales also, 0 to 10. We ask them, out of 0 to 10, how do you rate your pain? To understand, 0 to 3 is mild pain, 3 to 6 is moderate, more than 7 is severe pain. There's also percentage scale. Out of 100%, do you have 25% pain, 50% pain, 80% pain? So this we try to understand during the follow-up after medications are given. Is the medications helping him to relieve the pain? How much has it relieved? Do we have to increase his medication or add few more medications to relieve his pain? This is how we try to do it. Now, in case of persons who are non-verbal, person who has dementia, who is unconscious, cannot speak, in them also we have certain scales called Painard scale, Paxlack scale, Doloper scale. You can go through the internet and go through all these scales where, we can also try to understand the severity of pain in those patients who are unconscious, who are dementia, who are not able to talk. There's something called Flack scale. This is used for neonates, infants, where, we see into their face, legs, cry, their activity and consolability. Nurses can use this, to assess pain in the child. This is also available on net. And if you go through it and read in detail, you'll get to understand it's a best used scale in case of neonates. This is the pain art scale which I've put up here, especially for patients with advanced dementia who is non-verbal. They are not able to comprehend or no cognition, or they are not able to express themselves. This is the pain art scale to assess the pain what they have. So thank you so much. I hope I have done my sincere job here. I'm glad to take up any questions.
Yeah, so now it is a question and answer session. So if anyone wants to ask questions, they can do that. Anyone in the audience who wants to ask any questions, you're welcome.
Doctor, I am Rupa Tantri speaking here.
Yes.
My
yes.
my 83-year-old mother attended your talk. She very interestingly she listened to your talk. She can understand English, but she cannot speak in English.
Okay.
She wants to give her feedback in Kannada. Can I unmute her audio?
Sure. You can, if okay, I would love to see her also, and she's one of my favorite friends too. Hello, Amma.
ನಮಸ್ಕಾರ.
ನಮಸ್ಕಾರ ಅಮ್ಮ, ಹೇಗಿದ್ದೀರಾ?
ನಾನು ಇದ್ದೇನೆ ನನ್ನಷ್ಟಕ್ಕೆ. ಓಡಾಡೋದು ಸ್ವಲ್ಪ ಕಷ್ಟ ಆಗಿದೆ. ಆದ್ರೆ ನಿಮ್ಮನ್ನು ತುಂಬಾ ನೆನಪಾಗ್ತದೆ ನನ್ಗೆ. ನೀವು ಕೊಟ್ಟ ಟ್ರೀಟ್ಮೆಂಟ್ ನಮ್ಮ ಯಜಮಾನಿಗೆ ಸ್ವಲ್ಪ ಸಹ ನೋವಾಗ್ತಾ ಇರ್ಲಿಲ್ಲ. ಅದೇ ನಂಗೆ ಮುಖ್ಯ ಬೇಕಾಗಿತ್ತು. ಯಾವಾಗ್ಲೂ ನಿಮ್ಮನ್ನು ಮರೆಯುವುದಿಲ್ಲ. ನನ್ನ ಅವಸ್ಥೆ ಹೇಗಾಗ್ತದೆ ನೋಡ್ಬೇಕು.
ಥ್ಯಾಂಕ್ ಯು. ನೋಡಿ ಖುಷಿ ಆಯ್ತು ನಿಮ್ಮನ್ನ.
ಹೌದಲ್ಲ, ನನ್ಗೆ ಹಾಗೆ ಸುಮಾರೆಲ್ಲ ನೀವು ಹೇಳಿದೆಲ್ಲ ಅರ್ಥ ಆಯ್ತು. ಮಾತಾಡ್ಲಿಕ್ಕೆ ಇಂಗ್ಲಿಷ್ ಅಷ್ಟು ಬರುದಿಲ್ಲ ನಂಗೆ. ನಂಗೆ ಅಲ್ಲ, ಇದ್ರಲ್ಲಿ ತುಂಬಾ ಇಂಟ್ರೆಸ್ಟ್ ನಂಗೆ, ಕಾಯಿಲೆ ಬಗ್ಗೆ ತಿಳ್ಕೊಳ್ಳಿಕ್ಕೆ ಎಲ್ಲವಾ. ಅದು ತುಂಬಾ ಒಳ್ಳೇದಾಯ್ತು ನಂಗೆ.
ಒಂದು ದಿವಸ ಬೇಕಾದ್ರೆ ಡೈರೆಕ್ಟ್ಲಿ ಬಂದು ಕನ್ನಡದಲ್ಲೇ ಎಲ್ಲ ನಿಮ್ಮ ಹತ್ರ ಮಾತಾಡ್ಬೋದು ಇದ್ರ ಬಗ್ಗೆ, ಇಂಟ್ರೆಸ್ಟ್ ಇದ್ರೆ.
ಹೌದೌದು, ನಾನಿನ್ನ ಮಗನ ಮನೆಗೆ ಬರೋಳು ಇದ್ದೇನೆ, ಅವಾಗ ನೋಡುವ. ಥ್ಯಾಂಕ್ಸ್ ತುಂಬಾ.
ಥ್ಯಾಂಕ್ ಯು. Any other questions which could help you to understand this, or you can help your friends, family, to pick up pain, or if any of your family member is suffering from any disease condition, you can as well ask me questions, or you can directly mail it or WhatsApp to Rupa. She can pass it on to me. I can answer it to her then.
It was a wonderful session, Doctor.
Thank you.
Yeah. I too understood most of the concepts that you explained. Thank you very much.
Great.
So one request to all the participants, I have posted the feedback link in the chat box. Kindly, fill in that form for the certificates. And any more questions? Ma'am, I'm Professor Viraja, and I actually had one question. So actually, it is one of my friend who is in her 40s. Okay? And she gets this hip bone pain. So what could be the reason for it?
Okay. See, hip bone pain. So we will have to find, it's a localized pain, correct? It's only in that area.
Yeah.
Is it radiating? Does she also says the pain is radiating to other side, center of the spine?
No, she says that is starting from there and it passes through her leg completely. I mean, it's like that. So
yeah. There could be multiple reasons, Professor Viraja, right?
Yeah, Viraja.
Yeah. there could be see, at that particular site, we have so many anatomical structures there. We have the hip bone there. We have pelvis bone there. We have the neck of the femur there. At the hip joint, we have neck of femur, that is a thigh bone. We have the hip joint, the pelvis bone. Both these combine to form the hip joint. And there are nerves which is actually coming out through certain osteums, we call, through the hip, through the holes in the hip joint. So to tell you exactly from where the pain is coming, she requires a proper examination. It could be a sciatica, it could be related to a weak bone there. Sometimes, osteoarthritis, osteoporosis, or a sciatica, which is a nerve involvement. So there are multiple causes. So she will require to be checked properly, assessed properly, and then come up with a diagnosis.
Okay, madam. Then I'll have to suggest her
Yes.
because many a times she has ignored it. Sometimes it comes and sometimes it is not there. She says that. So this has been continuing after her, delivery, post-delivery things. It has started.
And the pain has been for more than 3 months, prolonged pain?
Ma'am, it is long time, not even 3 months, years together, I think.
Then it's a chronic pain. Looks like it's more a nerve-related pain. A neuropathic component seems to be involved. So
Okay. So it is better for her to consult a doctor, you would say, right, ma'am? Okay, ma'am. Thank you so much for this.
Thank you.
So are there any other questions? Participants, anyone else who wants to ask any questions there? Okay, I don't think. Yeah, any questions? Hello? Any question? Okay, I don't think there are any further questions, or shall we wait? Is there anyone who wants to ask any question to madam? If no, may I request Miss Sujita from IZ Group of Institutions to propose the vote of thanks? Sujita?
Yes, ma'am. Yes, ma'am.
Are you there? Yeah, please.
Yes.
So can we have the vote of thanks?
Yeah, okay, ma'am. Good evening, one and all. For this auspicious gathering, the roots of all goodness lies in the soil of appreciation. On behalf of IC Group of Institution, it's an immense pleasure to thank our speaker, Dr. Kavita, for giving innovative information and a glimpse of knowledge in pain of assessing the palliative patients. At this moment, my heartily thanks to Disciples India Learning Forum in association with IC Group of Institution for organizing the webinar and adding knowledge in palliative care. It's my great honor to thank Mr. Shivaprasad and Dr. Rubashri for their coordination and untiring efforts for making the webinar success. And also I extend my joyful thanks to students, teachers, and the professors for their enthusiastic participation. Once again, I thank you all. Thank you, ma'am.
Thank you, Sujita. Thank you, ma'am. It was a wonderful session, I would say. Pain has so many aspects I really didn't know. Today is the day when I got to know that there are so many aspects in pain. Okay, thank you so much, ma'am. Thank you.
Thank you.